We're going to deal here with pancreatitis. We're going to talk about both acute pancreatitis and chronic pancreatitis with a little bit more focus on acute pancreatitis since we talked about the chronic form in the malabsorption section. So this is just our schematic. We're going to be focusing on the pancreas and the common bile duct. Those are the two parts that are implicated in pancreatitis, and I suppose you could also say the gallbladder is as well. So what is the pancreas? Let's just review here. The pancreas is both an exocrine and an endocrine organ. So 4 of these things are going to go into the blood. 2 of these things are going to go into the gut. So into the blood, you got insulin, glucagon, somatostatin, and pancreatic peptide. Insulin and glucagon, as you remember, they regulate the blood sugar. So insulin will increase cellular uptake of glucose, and glucagon will decrease the cellular uptake of glucose. As far as amylase and lipase, amylase breaks down carbohydrates, and lipase breaks down fats. And the pancreas is a cystic structure. It's located posterior to the stomach, and so on this diagram, the stomach is cut here, so you don't see the stomach, and the pancreas is right behind it. And you do see anatomically, if you were to cut somebody right down the middle, you would see a little bit of the pancreas and then the duct, and the duodenum sort of wraps around it. But primarily the pancreas is posterior to the stomach. Okay, so as far as acute pancreatitis is a sudden inflammation of the parenchyma of the pancreas. The most common cause of acute pancreatitis in the United States are alcoholism and gallstones. It's really important to remember the risk factors here for gallstones because this is going to change how we manage the patient. If the patient has acute pancreatitis that's due to alcoholism, we're going to treat them one way, whereas if the patient has risk factors for gallstones, it might be worth getting that right upper quadrant ultrasound before we go ahead and admit them to the wards. So remember the risk factors for gallstones, and they are fat, female, fertile, and in her 40s. There are some drugs that are directly toxic to the pancreas as well, and those include sulfa drugs, 6-mercaptopurine, valproate, which is a mood stabilizer and an anti-epileptic, and there are other drugs. Those are 3 of the more common drugs that I put on there. So as far as the mechanism of how this works, alcohol and these drugs are directly toxic to the parenchyma of the pancreas. As far as gallstones, what they do is they cause a backup. So if you look back to this diagram here, you'd see that there's a common duct where the pancreatic duct meets with the common bile duct. So you have your left hepatic duct, your right hepatic duct, your gallbladder duct, and then that's the common bile duct here, and then that meets up with the pancreatic duct, and that will empty into the duodenum. If you have a gallstone that gets right to the end of this common duct here, after the pancreatic duct, then you can get backup in the pancreas. So where the pancreatic duct becomes, the pressure inside the pancreatic duct becomes increased because you have a stone blocking the outward flow. And so the reason that pancreatitis forms in patients who get gallstones is if you have a gallstone in that location, you get an increase in intraductal pressure, and ultimately the ducts will not be able to hold the amylase and lipase. So when lipase and amylase are released from the pancreatic ducts and into the parenchymal tissue, this results in autodigestion and inflammation. So remember what the parenchyma are primarily made of. They're primarily made out of carbohydrates, fats, and proteins, just like the rest of our body. And lipase and amylase break down fats and sugars. So if you've got lipase and amylase going around in your pancreas, you're going to get autodigestion and therefore inflammation. So usually the stereotypical history that we see with patients with acute pancreatitis is the alcoholic or the patient with risk factors for gallstones, and that is fat, female, fertile, and in her 40s. And those together, I would say, make up approximately 70 to 80% of acute pancreatitis cases. Also, patients on sulfa drugs and the mood stabilizer valproate, those are also very commonly prescribed drugs, so keep an eye out for those. Another less common cause of acute pancreatitis is ERCP. So remember what ERCP is. It's endoscopic retrograde cholangiopancreatography. It's a way that we can visualize the bile duct system. And so this would be a case in which the doctor screwed up and caused pancreatitis by injecting the fluid, injecting the marker into the pancreas, and that can cause acute pancreatitis as well. So symptoms for acute pancreatitis, the most prominent symptom is going to be epigastric pain, and usually this is going to be severe enough that it's going to cause the patient to come into the ER, and that's going to be the number one chief complaint. And this epigastric pain is right over the middle of the abdomen, and it radiates to the back. So right around where you would expect your stomach to be. In the middle of the abdomen, maybe a little bit to the left, and then it radiates to the back. And that makes sense because the pancreas is in the back of the stomach. And so we would expect a more posterior pain than what we would expect in ulcer disease or gastritis. Nausea and vomiting are very common with acute pancreatitis, and fever and chills can happen as well just due to the inflammatory factors circulating in the blood. The pain tends to be worsened by eating, and of course that also makes sense because when you eat, you stimulate the pancreas, and if the pancreas is inflamed, then you're going to get release of enzymes and it's going to worsen your pancreatitis. So the pain is worsened by eating and with laying down. Again, you're stretching your abdomen when you do that, and so that's going to trigger the pain. So epigastric pain, severe, radiates to the back, worsened by eating, worsened by laying down, nausea, vomiting, fever. On physical exam, you're not really going to see a whole lot except for abdominal tenderness. So your next steps here are going to be in any patient where you might be suspecting acute pancreatitis. It's very, very important, especially if they've been vomiting, to make sure that you give them a normal saline bolus. And it's important for two reasons. One, they've been vomiting. Two, if they have acute pancreatitis, what can happen is they may be in a low fluid state. And that's due to the inflammatory factors that are circulating, and it causes third spacing of fluid. And so we need to make sure that these patients are hydrated. So a normal saline bolus would be a good first step in a patient where you'd suspect acute pancreatitis. And a lot of times the questions on the USMLE will tell you fluids have been started, So normal saline bolus won't be one of your choices. It will have already done that for you. But remember, fluids are going to be one of the most important things because we have to take care of the patient's ABCs. We don't want the patient's blood pressure to dip too far down. Pain meds are going to be important. These patients are in pain, and so you can use opiate or non-opiate drugs. It really doesn't matter. And then these patients are going to be immediately, until acute pancreatitis is ruled out, they're going to be NPO. And that's not going to be a problem with most patients since their pain is worsened by eating. The labs that you're going to want to get, and any time you suspect pancreatitis, you want to have your amylase and lipase. Those are really your diagnostic labs. You also want to get a CBC to check to see if there's any white blood cell elevation, and if so, how much, and you want to get a CMP as well. As far as diagnosing acute pancreatitis, that diagnosis can be made with your amylase and lipase, and it not only has to be above normal, but it's got to be more than 3 times the upper limit of normal. But in general, in patients who have acute pancreatitis, their amylase and lipase is going to be sky high. It's going to be much more than 3 times the upper limit of normal. It's not very difficult to get to that threshold when you're virtually spilling amylase and lipase right out into the blood. And sometimes this comes up on the test. Lipase is more specific for pancreatitis. Lipase is more specific than amylase. So when you've diagnosed acute pancreatitis, the next best step is to get an abdominal CT scan. And the reason is that the abdominal CT scan is going to give us the best indication of severity. The abdominal CT scan will show us inflammation, it will show us necrosis, it will show us hemorrhage, it will show us if there's any other complications in the pancreas. So the abdominal CT scan is the best first diagnostic step after you've made the diagnosis with your labs. Now, if you have a patient that is not an alcoholic, let's say she's a 46-year-old woman, she's still menstruating, she's got a BMI of 33, and she's fat, and she's a woman, she's got risk factors for gallstones. And so it may be judicial after the abdominal CT scan to get a right upper quadrant ultrasound. And if the cause indeed is gallstones, then a cholecystectomy should be undertaken at some point, because this is a patient who's not only got gallstones that are giving her problems, which itself would be an indication for cholecystectomy, but it's actually putting her in a life-threatening situation. Now, as I mentioned, the best way to indicate the severity of acute pancreatitis is with an abdominal CT scan. There is another way that's been used much longer to evaluate acute pancreatitis and its severity, and that's called Ranson's criteria. And what Ranson's criteria is it's a set of 11 different criteria, and they are correlated with the survivability of the episode. Now, the USMLE is not going to directly ask you to calculate a Ranson score and then ask you what the survivability is or what the mortality rate would be. But what you should know is what the Ranson's criteria are on admission as a general idea, and how that classifies pancreatitis without the CT scan as mild acute pancreatitis or severe acute pancreatitis. So all of these things here, and you can write them out as WALLS, W-A-L-L-S, all of these things would be positive if they fit these criteria. And the more positive factors, the worse this patient is off. So if you have white blood cells greater than 16, that would be a positive. So actually a negative, but it would be plus 1 point. If the age is greater than 55, that would be a point. If the AST, which is a liver enzyme, is greater than 250, that would be another point. If the LDH is greater than 350, that would be another point. And if the glucose is greater than 200, that would be another point. And generally the way that this is analyzed is if it's 0, 1, or 2 points, then it's considered that severe pancreatitis is unlikely. And so, pending the results of the abdominal CT scan, pending the read, etc., we can go ahead and treat this as mild acute pancreatitis. If the patient has 3 to 5 points out of these 5, then severe pancreatitis is likely, and we should presumably start treating them as severe pancreatitis, and that means ICU admissions, possibly antibiotics. But don't forget that the number one best indicator of severity is not Ranson's criteria, it is the CT scan. So here's the rest of Ranson's criteria. We sort of went over all of these. On admission, you have WALLS here, so I didn't put that in that exact order. At 48 hours, the mnemonic is faux chub, and again, I didn't put it in that order, but F would be sequestration of fluids would be greater than 6 liters, and that would just be a change in the patient's weight as you'd measure that. O would be the partial pressure of oxygen being less than 60 millimeters of mercury. C would be the serum calcium is less than 8. H would be the hematocrit would be greater than 10% fall from admission. U would be the blood urea nitrogen, will have increased more than 5 milligrams per deciliter after hydration, and the B would be a base deficit of greater than 4 milliequivalents per liter. And this, after 48 hours, then you can assess what the patient's mortality rate would be. Now, I just want to bring up some pathophysiology things real quick right here. So why would the serum calcium be low in a patient with acute pancreatitis? Acute pancreatitis means you're going to have a low amount of lipase in your gut because the lipase is being secreted into the blood. So if you have low lipase in your gut, then you're not going to be able to break fats down. And in order to absorb calcium, you have to be able to break fats down. And so calcium will be low in patients with acute pancreatitis. As far as the BUN will normally be a little bit higher when you admit them, but that should go down after you hydrate them. And you simply have a high BUN because you've got a dehydrated state. So after you hydrate them, if their BUN is still more than 5 milligrams per deciliter above normal, then that's going to be another checked off criteria. And then the sequestration of fluids is going to be related to the inflammatory mediators. So how do we treat acute pancreatitis? So if the patient has a CT that comes back as a mild acute pancreatitis, or let's say presumptively if they fit 2 or fewer of the initial Ranson's criteria, then what we're primarily going to do is supportive care. We're going to give them IV maintenance because we don't want them taking anything through their mouth, so no food, no drink, IV maintenance, and pain meds should be taken as needed. Now, as the patient begins to, as the acute pancreatitis begins to remit, then we can wean them towards PO pain meds. And as the pain begins to remit, we can also wean them towards oral feeding. And once they can get their total nutrition on their own, and they're weaned to PO pain meds, then we can go ahead, we can stop the IV, and we can start discharging them. We do want to continue getting an amylase and lipase on these patients, though, because sometimes they can move into the severe or hemorrhagic pancreatitis. So we want to monitor their amylase and lipase and make sure that they're going down as they should. Now, if the patient has a severe or hemorrhagic pancreatitis based on CT or presumptively based on your initial Ranson's criteria, you're going to want to admit this patient to the ICU. There's 2 really important things that you should be doing, and one is to start broad-spectrum antibiotics. And you're not going to be starting these antibiotics because the patient is infected. You're going to start these antibiotics because the patient has a likelihood of becoming infected. So it's really a prophylaxis. You can use any of the carbapenems, but preferably you should use imipenem, or you could also use cefuroxime. So imipenem or cefuroxime should be started in severe pancreatitis. These patients should be in the ICU, and of course they should have their temperature monitored closely because we want to see if they're moving toward a septic state. They should have serial labs done, and by serial labs I mean CBC, CMP, etc., because we want to check their end organ states. We're worried about renal perfusion. We're worried about blood oxygenation. So those are going to be really important as well. Like your other pancreatitis patients, they should be on IV maintenance. Pain meds should be given as needed, and they should be NPO. And the whole NPO thing behind pancreatitis is because we don't want to stimulate their pancreas while it's healing. In order to heal the pancreas, you've got to give it a rest. And if there's no improvement in these patients in 7 days, then you can go ahead and do a percutaneous aspiration. And that's going to tell you if this patient is indeed infected. And generally, the ones that you're going to need to do percutaneous aspirations on are the ones that you haven't started imipenem or cefuroxime on. That's not necessary. I wrote may start. You don't have to give them. It's not written in stone that you have to give them prophylactic coverage. Some do and some don't, but that's something that you can think about. So if there's no improvement in 7 days, go ahead with percutaneous aspiration. And if the aspiration comes back infected, as it usually would, then you're going to start imipenem or cefuroxime, and you should consult surgery for debridement. And in that case, that's going to be where you're actually going to take out the pancreatic tissue that's infected. Generally, if you've already started imipenem and cefuroxime and there's been no improvement, then you're just going to have to go ahead and consult surgery for debridement right there. Okay, so here's some CTs, and you probably won't get CTs this in-depth on step 2, possibly on step 3. But this is a normal pancreas here, and you can see that the pancreas has a lobular cystic structure. It's got various regions of high opacity and low opacity, and that's very characteristic of the pancreas. So it's kind of like that, kind of like when you hit the wrong channel on the TV. It's that lobular structure that that you should associate with the pancreas. Now compare that here to this is an acute pancreatitis. You've kind of got a loss of that. The pancreas is a lot more homogeneous, and that's because it's inflamed. There's more fluid inside of it. Here you have less fluid, it's more lobular, and here you have more fluid, and so it's more homogeneous. So this is acute pancreatitis. This is another acute pancreatitis here. Again, it's the pancreas, apart from being larger, it's more homogeneous. And this is a severe pancreatitis, and this was the most obvious one I could find. But the pancreas has completely lost its structure, and in addition to that, there are foci of infection. So after you've discharged the patient with acute pancreatitis, once you've gotten them out, you should advise them of risk factors, particularly alcoholism. If they did have pancreatitis due to gallstones, you should get them set up for a cholecystectomy if you haven't done so already, and the patient should be rechecked in 7 to 10 days. One of the big complications of acute pancreatitis is the pancreatic pseudocyst, and what that is you've got weak tissue in your pancreas, because it's been inflamed, and so you can get a cystic formation from pancreatic tissue. It's kind of like an aneurysm of the pancreas, so to say. It's weak tissue that's now become cystic, and usually this will present as a dull pain if it's even symptomatic at all. Sometimes you can feel it as a palpable mass. Any patient that's a few weeks away from acute pancreatitis, so we're not talking 6, 7, 8 months down the road. We're talking like 3 or 4 weeks after being discharged, and they present with similar pain to acute pancreatitis, you should be getting them, you should have an eye out for pancreatic pseudocyst, and this will be diagnosed on CT. Keep your hands out for a palpable mass. But like I said, generally these are in patients who are a month or 2 past acute pancreatitis, and that will tend to be the giveaway in the vignette. Confirm this with CT. You want to differentiate this from other possible masses, of course. And the only time you're going to treat these, by treating I mean aspirating, is if they're greater than 5 centimeters, if they're growing, or if they're symptomatic. And usually if the patient came into the hospital, they're symptomatic. So sometimes you can see these coincidentally, but in general on the USMLE, this is going to be something that you're going to drain. So here's a pancreatic pseudocyst. Notice that you have a totally homogeneous inside of this cyst. And same here. It's practically all homogeneous. This would be completely different from if this were pus. It would look totally different. I should have put one on there, but I didn't. So you got a homogeneous fluid on the inside, and you can drain that. Chronic pancreatitis, we sort of talked about in the malabsorption section, so we're not going to give a whole lot of time to that. So chronic inflammation, chronic pancreatitis is caused by chronic inflammation and fibrosis of the parenchymal tissue of the pancreas. Usually it's due to repeated insult, so these will be patients that have had multiple episodes of acute pancreatitis in the past. And what happens is, as you have inflammation over and over and over again, what gets laid down is fibrin and collagen, and then the pancreas cells in this case are going to begin hypofunctioning, and ultimately they'll cease to function at all. So it's kind of like cirrhosis of the pancreas. Characteristically, this is seen in patients with chronic alcoholism, but it can also be seen in patients with cystic fibrosis and in any other patients who've had repeated pancreatic stress. Some autoimmune disorders present with chronic pancreatitis, such as autoimmune pancreatitis, and Sjogren's syndrome, I guess, wouldn't present as chronic pancreatitis, but you can get chronic pancreatitis with that constellation of autoimmune problems. And then approximately 10% of chronic pancreatitis cases are idiopathic. The symptoms for chronic pancreatitis are going to be sudden attacks of mild to severe pain. They shouldn't be quite as severe as acute pancreatitis, but pain is subjective, so it's really difficult to know how severe the pain is for the patient. But a lot of these patients, like I said, will have had acute pancreatitis. So if you ask them, is this the worst pain like this you've ever had, usually they'll say no. But sudden attacks of mild to severe pain, just like acute pancreatitis, is one of the symptoms. Another symptom, and this is sort of telltale, is weight loss, malnutrition, and vitamin deficiency. And the reason is because these patients aren't putting out lipase into their large intestine, and they haven't for a long time, so they are not absorbing fat. And if they're not absorbing fat, they're not absorbing the fat-soluble vitamins A, D, E, and K. The labs you're going to get to work this patient up are similar to the labs that you're going to get for acute pancreatitis. You're going to want to have your amylase and lipase, but specific to chronic pancreatitis, you're going to want to get an abdominal plain film. That's not an abdominal CT. That's just an X-ray of the abdomen. You'll want to get a fecal fat test and a CBC. And so here's what you would see in about 30% of patients with chronic pancreatitis. And this is a CT here because I wanted to show it better, but you should be getting an abdominal plain film. And here you can see in the region just to the left and right where the stomach is, you see calcifications, and they're very, very shiny. Same thing here on CT, but you should be getting an abdominal plain film. So what will our labs tell us in chronic pancreatitis? Our amylase and lipase, primarily we get this to exclude acute pancreatitis. There's no really lab results from amylase and lipase that are necessarily going to tell us chronic pancreatitis. But what it can tell us is that it's not acute pancreatitis. So remember, in acute pancreatitis, your amylase and lipase will have to be greater than 3 times the upper limit of normal. In chronic pancreatitis, it can be variable. It might be slightly elevated, it could be normal, or it could be depressed. But it won't be 3 times the upper limit of normal as it is in acute. On the abdominal plain film, as we just saw, about 1 in every 3 patients will have calcifications in the area of the pancreas. A fecal fat test can be useful because that will show fat malabsorption, and that would be expected in a patient with chronic pancreatitis. And then a CBC can be useful. These are just some of the routine labs. CBC and a macrocytic anemia, so a high MCV and a low hemoglobin. That would show that you may have a patient with long-standing alcoholism. And long-standing alcoholism is a cause of chronic pancreatitis. So that can be another clue. For treatment, we are going to give these patients pancreatic enzyme replacement therapy, and that's to help with their malabsorption and their malnutrition. We want to modify risk factors, so cut off the alcohol if we can, and oral analgesics are okay for the pain. If these patients are in so much pain, if they're vomiting, if they're throwing up, and we can't send these patients home for one reason or another, if they're not stable enough, then we can admit them to the hospital and we'll just treat them similar to the uncomplicated acute pancreatitis, in which case we're pretty much just keeping them NPO for a little while, giving them oral analgesics, and hydration.